and Humanities here at the University of Virginia School of Medicine. I'm Marcia Day Childress from the Center for Biomedical Ethics and Humanities. So who here is on Facebook? Hands? Who Twitters? Not so many. Who blogs? Okay. Do you have patients who update family and friends on their treatment or convalescence using a website like Caring Bridge? Who's seen somebody else's surgery on YouTube? Or your own?
Nice. It looks really good.
Today's program is called Medical Confidentiality in the Age of Social Media. Confidentiality in healthcare, as you know, is a core principle of bioethics. Traditionally, assured that their health information will be held in strict confidence by a small community of care providers, patients generally feel they can speak freely to those providers, and they feel protected from unwanted discrimination, embarrassment, and social accountability. But this understanding of medical confidentiality, which was challenged in recent years by just the sheer number of providers who had legitimate access to patients' medical records, is challenged anew today, and perhaps in more sweeping ways, by a raft of new social practices, the ones you raised your hands about. So how do we think about medical confidentiality in a world where people post health results on Twitter and Facebook, discuss intimacies of symptom, diagnosis, and treatment on websites, their own or others, where people live stream childbirths and surgeries, use their phone apps for health monitoring, voluntarily upload health information to the cloud where HIPAA doesn't apply? What does medical confidentiality mean now? In this Medical Center Hour, which is the Hollingsworth Lecture in Ethics underwritten by the university's Institute for Practical Ethics and Public Life, Professor Anita L seeks to make sense of medical confidentiality in our current age of revelation. Professor Allen is the Henry R. Silverman Professor of Law and Professor of Philosophy at the University of Pennsylvania. She's also a member of the current Presidential Commission for the Study of Bioethical Issues, appointed by President Obama. She's an expert on privacy and confidentiality in healthcare. Indeed, her newest book, Unpopular Privacy, is just out this week from Oxford University Press. And if you noticed when you came in at the upper end of the auditorium, the UVA bookstore is here with copies of the book for sale, and I think she'd be happy to sign anyone's copy if you'd like that afterwards. I'd like to thank the Institute for Practical Ethics and Public Life for working with us on this program. I'd also like to point out to you, and this is also in your handout, that the Institute will be sponsoring a second talk by Anita Allen this afternoon, 4 o'clock to 5:15, in Clark Hall, room 107, Moral Life and Mental Illness, in which Professor Allen will be offering a fresh perspective on the moral and ethical challenges of high-functioning persons affected by mental conditions. And she'll be drawing on some psychiatric memoirs in that conversation. So now, without further ado, please join me in welcoming Anita Allen.
Can everyone hear me? Thank you. Thank you. So I'm pleased to be here at the University of Virginia to talk about health privacy and social networks. And I mean by social networks both the online kind and the offline kind, the online kind, of course, being the most current and interesting. So I'm afraid that we are coming to dislike privacy, or we're becoming indifferent to it, or we even resent and despise it. It's not wanted. It's unpopular. And in the book that you just saw a copy of, Unpopular Privacy, What Must We Hide, I have a chapter in which I talk about my concern that privacy is becoming unpopular and that we should not allow that to happen, to continue. I believe that privacy is a foundational good of great importance to humanity, that it's a good on which other goods rest. So if you don't have privacy, there are other things which you also do not have that you need. So I'm a defender of privacy. I'm also a defender of a position that my privacy law colleagues call privacy paternalism, which is a view that it's sometimes okay to mandate, coerce, thrust privacy on people who may not even want it. So it's not all about autonomy. I think privacy is a deeper and richer virtue than that. So I want to talk today about some of the special challenges in thinking about privacy in this era of personal revelation, in the era of social networks. So I start with the question, where is our health data? Literally, where is it? Okay? It's where we put it voluntarily. And you might think, well, if we put it there voluntarily, there's no issue. So go home. Right? It's also where other people put it, in which case we may think we have moral and legal rights against its being put there. Or we may just have to accept the fact that it's out there and others can't access it. But where is it literally? It is, as the slide collage suggests, it's in doctors' offices, electronic health records. It's on Facebook. It's on MySpace. It's in patient forums. It's in large data banks, like the one shown here at the European National Biobank. It's on Twitter. It's in Dropbox. I use the cloud. Perhaps you use the cloud too to store your data. It's in court records, which are available online. It's in whole genome sequencing results hidden away there. It's also in our brains, in our minds, in terms of our beliefs, our values, our secrets. It's all there. And a lot of it is accessible, and we have to worry about which of it is accessible and which of it should not be accessible, if it is. So, why does it matter? In a big picture sense, privacy, confidentiality, and healthcare matters for the same reason that all privacy matters, because it's, again, a foundational good on which other goods rest. Without privacy, we could not have many things that we value, like peace of mind, like non-discrimination, like control. But in particular, what is the value of healthcare privacy? Why does healthcare privacy matter? The reasons are familiar to many of you. I see a lot of white coats there, and we've heard this for 1,000 years. Privacy and confidentiality have value because they encourage care seeking. People will be more willing to go to the doctor if they know that there's confidentiality. Confidentiality encourages full and frank disclosures. It reduces the likelihood of stigma, discrimination, embarrassment, shame. It protects autonomy and dignity. Because again, if I have confidentiality, I have a bit more control. I can control whether or not I'm respected and how I'm respected, how I'm regarded. And then finally, because we think that early interventions are cheaper interventions, we associate confidentiality with lower healthcare costs. So that's a fairly standard portrayal of why privacy is important, why it matters if we have confidentiality or not. One of the things I like to emphasize in my writing and in the book chapter that I just published on confidentiality is that confidentiality cannot just be seen as a professional virtue, something good doctors and good hospitals, good nurses, good technicians adhere to. It's really a burden, and it's a nasty thing. It's a burden. It gets in our way, it interferes. And why is it a burden? Because being able to talk about our work, being able to share our concerns with other people beyond the patient, being able to gossip, being able to satisfy our curiosity. These are very human things, and confidentiality rules and norms say you have to keep quiet, you have to shut up about that, you can't talk about that. So it's a burden. It is a burden that some of us embrace willingly, but it definitely is a burden. That's sort of our starting point. It's a burden. So what justifies a good, just, liberal society imposing confidentiality on medical professionals and others is because we believe that we reap all these important public and private benefits from doing so. I'm fond of telling people a story of how as a lawyer, I sometimes hear secrets from clients, and I can't tell people, even if I know amazing things. I told the story this morning about knowing a crime, a notorious crime happened in my community, and everyone was worried. Who would do such a horrific thing? Well, the perpetrator came to my house and told me. I did it. And I had to keep the secret. I still kept the secret for all these years. But it would have been wonderful to be able to be the good citizen who goes to the police and say, here's your guy or your gal, arrest them. But I couldn't do that. I still haven't done it. It's a burden. It burdens conscience to have to keep things a secret. It's not fun. But it is a virtue, and one which I think has a lot of credit to it. There are a lot of cutting-edge issues today that raise problems of confidentiality, concerns about confidentiality. And I don't want so much to talk about those today, because I think that we have so many more basic ones, so many more everyday ones to think about. We could be talking about genetic testing and biobanking and whole genome sequencing and neuroimaging. And I'm proud to say that the President's Commission will be addressing some of these cutting-edge issues in the months ahead, especially whole genome sequencing and neuroimaging, issues about confidentiality and privacy and access to information in the research context and the forensic context. Very important questions. But I want to today focus more on what I regard as the everyday kinds of privacy and confidentiality challenges, starting with problems of social networks. So let me tell you some stories that will kind of get your juices flowing on this topic. First story I call the case of the phlebotomist. This is a hospital worker whose job was to take blood. And when reports came back about who has infections, who's pregnant, she would be the person to get those reports. And one day she got a report. This is an Illinois woman at a hospital called the Leading Health Systems. She got a report saying that a friend of hers who'd been in was pregnant. So a couple days later, she goes to a restaurant, and who does she see? Well, she sees the pregnant patient's twin sister. She says, oh my God, your sister's pregnant. She says, she is? I didn't know. Well, now she knew, right? So the phlebotomist had breached confidentiality by speaking about a patient matter outside the hospital context. She felt it was okay because she assumed a certain social network, a certain system of confidentiality that would make it hard to imagine that a sister would not tell about the pregnancy. She got sued, and the hospital got sued, and of course they were not in a very good position to defend themselves. It was just flat out breach of confidentiality. We don't regard social assumptions of individual employees as reasons to override our confidentiality rules. Another story. This one doesn't involve so much an informational privacy disclosure, but a certain sensitivity to other people's health data and health products that suggest we're in trouble when it comes to what might be the potential of Facebook to be a real problem with privacy in the healthcare field. So the case of the fresh placenta. Nursing student is in a class at a community college nursing program, and they're being asked one day in an OBGYN rotation to examine fresh placenta, recently delivered pregnancies. And three young ladies, including the one who brought the lawsuit I'm going to describe in a second, they decided they wanted to photograph themselves for Facebook examining the placenta. They asked the nurse supervisor, who said, just make sure there's nothing to identify the patient in the picture. No problem. And after the girls had photographed themselves with the placenta, they then were asked by the supervisor, well, what do you intend to do with the photographs? They said, we're going to put them on Facebook. And she said, oh, you girls. Those exact words. So when the school found out that the four nursing students had posted pictures of themselves on Facebook with placenta, they expelled the girls from school, kicked them out. And one of the girls brought a lawsuit saying, you can't kick me out of school for this. I didn't break any rule. And she actually won her lawsuit. The judge enjoined the expulsion on several grounds. One of them was that no identifying patient information had been disclosed. The other was that the school didn't have a clear-cut policy or rule against such a thing. Third was that the nursing supervisor had an opportunity to protest and to object, but she did not. And the result was that they felt the nursing student deserved to be admitted back into school, and she was. And also they said anything she missed, you got to let her make it up, right? The court was really unsympathetic. But I think this is a worrisome problem that someone might be permitted or allowed or not punished for what was done. Maybe there should have been better education about this, but think about the patient's point of view here. Perhaps you just had a stillborn child, right? And now the next day on Facebook, there are these nurses from your hospital parading placenta around, right? Or maybe your baby was born with severe disabilities and you're still grieving, and yet there are these nursing students with big grins on their faces parading around the placenta, which could be yours. So there's a kind of, I think, a tendency these days among healthcare professionals, especially the younger ones, if I can be a little critical of the younger generation, to go to Facebook with everything. And I think that today it could be the fresh placenta, tomorrow it could be something from which a patient's identity could be determined rather more easily. And the next case sort of shows how this might happen. This is a case I call rotten candy, which is about family networks and about social networks on the internet. So in this example, again, these are all real cases. I don't make things up, I don't have to. In this example, a woman named Candace Yap, went to her healthcare provider hospital to be examined for possible STDs. She'd been having an extramarital affair, and she was concerned. So she went to the hospital, and sure enough, she had an STD. She was treated for it. And she did tell her doctor that she had been involved in adultery, and the doctor wrote, extramarital affair, STD, blah, 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 all into her electronic health record. So on her way out of the hospital, a relative of her husband happens to see her. Why is Candace here? Why is Candy here? She decides to go online and check it out. She has authorization to look at patient records because she works in the hospital. And she sees that her husband's, her distant cousin's wife that has an STD is an adulteress. So she calls someone else to tell them about it, another family member. That family member calls the sister of Candace's husband and tells her. And then the sister calls her brother and says, Candy's having an affair and has an STD, right? And so the information goes from the doctor's office, as it were, to back to the family of the patient. Well, the husband institutes divorce proceedings against Candace, and that's sad and bad enough. But what makes it even worse is that a family member's friend put up a MySpace page, called it Rotten Candy, calling her an adulteress, a dirty person with an STD, and it even belittled her for having had cosmetic surgery in the past. The thing I liked about this case in terms of how it turned out legally is the court did recognize that posting someone's medical information on MySpace is no different from publishing it in the newspaper or publishing it in broadcasting on the radio or on television. It's the same thing. And even if you don't know exactly how many hits that, how many people visited the site, doing it is a publication of private fact. All right, so there was potential for liability for what happened to Rotten Candy, as it were. But these three examples, I think, show how the norm of confidentiality and privacy, as important as it may be, it conflicts with social practices and social values. I bet those people who thought they were telling on Candy thought they were doing the right thing. Why should her husband be forced to live with an adulteress with STDs? I think that the phlebotomist thought that she was literally perfectly innocent. I think that the nursing students who are proud of their education, their opportunity to learn and to handle important matters, they're flaunting their education. They thought was not a bad thing to do. But all those things do put patient privacy greatly at risk. So the previous examples show how people can have privacy taken away from them by others who don't value privacy as much as they value other things, their social life, their family, kinship values, and so forth. There's also plenty of things happening nowadays that represent our giving away our privacy, just giving it up. For example, the use of cloud services. You didn't ask them how many have Dropbox. How many have Dropbox? Okay, so we are uploading our data from our iPads or our laptops or our home computers to the cloud, where a third party is storing and safekeeping our data for us. In theory, I could put my mammogram films in Dropbox. I could put my lab results up there. Anything tied to my healthcare up there voluntarily, because I think it's safer there than on my home computer or my laptop, which might get broken or stolen. But ask the question, well, who has access to what's in Dropbox? Are there any laws or rules or ethical codes that protect my data in Dropbox or Google Cloud or Microsoft Cloud services from being taken by third parties? Many health management companies are moving data to the cloud. They're now storing data on the cloud. By one report I saw, 30% of healthcare providers are currently using some kind of cloud-based service. And there's a real push by the industry to offer more privacy for sensitive data in order to attract more healthcare companies to the cloud. And then there are these sort of patient-driven web management services that many of us utilize, where we can go online and get a referral from our doctor, or get a prescription refill, or ask for an appointment, look at our lab results, look at our doctor's narrative reports about us. And a lot of these, like the one that we use at Penn, My Penn Medicine, have a little comment box. You can put anything in there, you know. I have a fever today, I'm warts developed, I'm incontinent for the third day in a row. And you don't really know like who's seeing that or what they do with it. You don't really know exactly who has access to the data, but you sort of feel like it's a good thing that you can communicate to your doctor in this way. But what are the risks? Are we giving away our own privacy, not knowing the parameters that we are operating within? There are many things we can do to protect our privacy better, but before I even get to those, I want to note a couple of other additional kind of new technology-oriented concerns that we need to be worrying about. I mentioned a few, but what about data breaches? What sort of concern does that raise? Because we're giving away our privacy, we're also having it taken away from us by private persons. But what about these sort of large data breaches that we're experiencing? So one of my favorites is Stanford University Hospital had hired a billing contractor called Multi Specialties Collection Services to help them with their medical data. And someone who worked for that company was concerned about how they could turn a spreadsheet set of data into a bar graph. So they went to a homework help site called Student of Fortune, where you can go to get help with your homework. And they asked the question, how can I turn this spreadsheet into a bar graph? And the spreadsheet in question contained names, diagnostic codes, account numbers, as well as admissions and discharge data for 20,000 patients who visited the ER at Stanford Hospital in 2009. And it was just there. It was up for a year on this student homework site. When Stanford found out, they had it taken down, but by then, it's too late, right? And under California law, data breaches are very strictly punished, and so the hospital ends up being fined $250,000 by the California Department of Public Health. But that, if it happened at all, is amazing. You've heard of the lost truck's load of tapes from Johns Hopkins and other similar issues. And then on a more personal side, think of all the ways in which individual people, by virtue of choices they make to use the resources of, for example, the criminal justice system, can end up having their data end up on the web. So one of my favorite cases is, I like favorite cases, but there was a woman named Elaine who suffered from psoriasis, and she went to an organization called Connecticut Community for Addiction Recovery and Counseling. And she went there for life skills training. How can I cope with my horrible, disfiguring psoriasis? Now, most of their patients were drug addicts, alcohol abusers, but smokers. But she went there for life skills around and therapy around dealing with her psoriasis. Well, the therapist that she talked to there talked about Elaine with other people in the office. An interesting patient, unusual patient. She has psoriasis. And then when it came time to prepare their annual summary of their work, the center posted on a website some of the summaries of their interesting cases, including the case of Elaine, real name, with psoriasis on their publicly accessible website. They think they're doing educational good, because now people understand they don't just deal with drug addicts, they also deal with people who have medical problems of different sorts that might need some counseling and life skills support. So Elaine sued for invasion of privacy on the grounds that, first of all, her therapist disclosed her illness beyond the therapist-patient relationship. Offense number one. Offense number two, counseling service, CAR, again, Connecticut Community for Addiction and Recovery, they published on their website something that was identifiable enough that some people said, isn't that you, Elaine? That's you, Elaine. You, Elaine, with psoriasis. How many Elaines with psoriasis, So her lawsuit was not as well received by the courts as you might think. I mean, it was the court found that actually her first name only combined with her condition wasn't especially revealing. A South Carolina man filed a lawsuit against the prison which he was incarcerated, complaining of prison conditions which were inhumane and cruel and unfair. And in his lawsuit, he, of course, faced the big defendant, the state. And the state, in response to his lawsuit, filed court papers in which they attached information that they had in their possession about him, namely his entire life story, his entire mental health record, and all of his physical health information as well. And I would imagine they believe that this record of his health history was relevant to whether or not he was getting appropriate care in prison. But unsurprisingly, the man did not like the fact that due to the new openness about public criminal records, we can now all go online and see what used to be hidden away in filing cabinets. That which used to be obscure is now in the open. And does he raise a good point here? Is this a good claim he's making? Is he really justified in feeling that his medical record should not be made public just because he filed a lawsuit? And then a case from Virginia about a bankruptcy debtor. Virginia man who filed for bankruptcy. He'd seen an orthopedist and had racked up a huge medical bill. He had other problems as well. And in their claim of proof, or proof of claim, excuse me, for some settlement in bankruptcy, the orthopedics group attached to their file, their claim, his entire medical record they had in their possessions. Social Security number, home and work phone number, insurance carrier, and all this confidential medical information, all there in the bankruptcy record. And nowadays, due to federal changes, bankruptcy records are available online. And so you can go and read about your neighbor's bankruptcy. You can see all the debts they have and so forth. But there are within most bankruptcy jurisdictions, well, federal jurisdictions, but most bankruptcy courts really strictly enforce the need to redact sensitive information from the bankruptcy filings. But in this case, that wasn't done. It all went out there, all on the internet. So it came back, but by then it's too late. You have a snapshot on Google. So these are the kinds of problems that are being faced in the current time, and I think a lot of these problems arise because there's not an adequate sense of what's of value in protecting privacy. Privacy is losing out to other values such as administrative convenience or government accountability or family loyalties and so forth. So here's my sense of what we can do to better protect privacy. So one thing we can do, of course, is pretty obvious. We need to maintain professional ethics. Because some of these social media offenses relate to people perhaps not having a strong and committed relationship to ethics as they ought to. So we have to keep teaching it, as you do here, keep teaching it, keep learning it as professionals and students. And to internalize it, to make it automatic, to think it would be inconceivable that you would speak to a family member of a patient about that patient's condition outside the hospital especially. Should not be thinkable to post a placenta picture or to set up the MySpace page or tell people who might do such a thing about a patient's medical information. So that's sort of step one. And in saying this, I'm not intending to in any way pick on medical people, because lawyers, accountants, tax preparers, school teachers, lots of professions have needs to protect confidentiality, and lots of mistakes have been made. Think about those passport workers who went into the passport files to look at the passports of Barack Obama and other presidential hopefuls back in 2008. Is that recently? 2008? Okay. So lots of professionals have access to sensitive data. Lots of them breach it. Lots of them need this teaching, learning, and internalization. It's not just about doctors and nurses. We also, though, need to do something that's a little bit trickier. And I think one of the most interesting parts of my new book, actually, is my effort to articulate the need to revive reserve as a virtue. Reserve. Revive discretion as a value. And in my afterword, I actually go back 2,000 years to the founding father era to find in some diaries of John Madison the argument for being a person of reserve. And he makes a fairly utilitarian argument there that we need to protect ourselves from the harm that our friends and our foes can do us if we entrust them with personal information. And I also end up citing the Bible, because in the book of Matthew there's a wonderful passage about why we should pray, give alms, and fast privately. You know, our reward is not that we're going to impress our neighbors and friends. Our reward is in heaven, or in the secular equivalent of heaven. It's intrinsically valuable to be reserved, to be discreet about our virtues and our vices. I think we need to start to demand greater levels of trust and integrity in our interpersonal relationships. We need to sort of expect trust and integrity and to earn it as well. I think that in part because of the novelty of being able to share everything with everybody quickly, we've kind of lost the customs and traditions of conversation and dialogue of a slower, more deliberate form in which we can grow to understand why we shouldn't give up information of ourselves and others so quickly and readily. We need to advance and invest in data security. You shouldn't lose a truckload of electronic records. You shouldn't make it possible. It shouldn't be possible for your contractors or subcontractors to upload Excel sheets containing 20,000 emergency patients' health data. We can do stuff that involves training, but also involves some technology. We have electronic methods to make data more secure. And I'm surprised that the healthcare systems don't invest more. And you say, well, we invest plenty, but should they be investing more in safeguards to make it harder for an administrator in a hospital to go online and look at a patient's data when she has no relationship with that patient, or that make it harder to lose or be hacked into, right? So I think that we could probably up the ante when it comes to data security. And if we really love privacy, we really should be trying to invest more in data security. We should also encourage the businesses involved in healthcare to implement privacy ideals. I teach and write about privacy data protection law, and in our field, we talk a lot about fair information practices, generally accepted privacy principles, which come from the world of accounting and corporate life, and privacy by design, which is proactive privacy protection being built into the way we do things. And it seems to me that there should be more conversation in the healthcare field about adopting fair information practices, limiting access to information, security, accountability. That there should be more emphasis on those practices. And HIPAA, to some extent, does embody those kinds of things. And then finally, I think we need to accept and push legal regulation. We need tough, clear, and enforced health protections. I was very pleased to see that the Department of Health and Human Services Office of Civil Rights decided to begin to really emphasize HIPAA regulations and to really punish offenders. So this year, Cigna Health System of Prince George's County, Maryland, was fined $4.3 million. Why? Because they refused to give patients access to health data as HIPAA requires. And this huge fine was also imposed because Cigna had refused to cooperate with the federal government when it sought to investigate the patient's claims. But this, for me, is good news. Law can only do so much, in part because there are actually limits on what law can do. Some of you followed the case of IMS versus Sorrell, which came down from the Supreme Court earlier this year. This is a case in which the constitutionality of Virginia's pharmacy confidentiality law was tested. This is a law which prohibited data miners from getting access to physician prescription information from pharmacies, prevented that from happening because Vermont didn't want its data miners to be selling physician prescription data without the permission of the physician to drug companies who would then turn around and market drugs to doctors, applying the pressures of what you're not doing what your colleagues do, or you're using Zyprexa, maybe you should be using more Risperdal. They don't want that kind of pressure. So Vermont made that illegal. The Supreme Court said you can't do that, Vermont. It's an unconstitutional law. Well, why so? Well, it's a violation of the First Amendment, commercial free speech. Because when the data miners talk to the drug companies, and the drug companies talk to doctors, that's commercial free speech. You can't impair that. That's a constitutional right. So what's the risk here to patients? Well, they do de-anonymize. They do anonymize. No, de-anonymize. They do anonymize using algorithms. They anonymize the patient data when it goes to the data miner. The data miner gets the doctor's name, but not the patient's name. Now, there are some experts who believe that what can be anonymized can be de-anonymized, right? There's a concern there. So the Supreme Court was not worried about patient privacy. It was worried about doctors' need to accept that that drug companies and, more importantly, data mining companies have a constitutional right of access to information that's out there and made available to other kinds of actors. If Vermont wanted to keep the data miners away from your physician prescribing data, it'd have to bar everybody from the data, which would mean you have no longer a content-based restriction. So we can only do so much legally, right? But we should do something. We should do something like better enforce HIPAA. There are those who argue that that HIPAA should be stronger. That we should have a private right of action under HIPAA. We don't right now. You have to file a complaint with the Department of Health and Human Services and hope they investigate and take action. But some privacy advocates think that we really need to have patients empowered to directly sue their doctors and nurses and hospitals for invasions. I'm not going to take a position on that right now, but I do think that the issues are pretty clear that we need to do something because right now there's not adequate protection for this very, very important thing we call medical privacy. Thank you.
Thank you very much, and we have a generous amount of time for some conversation on these issues. So I will move around with the mic and take your comments and questions. Who would like to start? Okay, let's see.
Yes, hi. Thank you for this interesting presentation. I'm Dr. Phyllis Kotshiris. I'm a clinical psychologist, and I'm the president of the Division of Media Psychology in the American Psych Association. And what I am wanting to do this year is to deal with media ethics. So that's why I came. And one of the issues you talk about adopting norms for the business sector. One of the sectors is the media. And we have a problem, I think, with the way people want to be giving away their privacy, just like you said, and professionals who are willing to have interview shows and talk shows where I think they take advantage of this privacy. So, we're trying to put together a media ethics manual about how to deal with this, and I wanted to hear your comments on that. So that's that side, and yet there's also the other side, which I'm sure someone will be commenting on, with the terrible tragedy we had at Virginia Tech, where now we're looking at maybe we sometimes hold on to privacy too much and we need to let it out. So I realize there's both sides of this issue, but I wonder if you could comment particularly on the first issue.
Right, so one problem with privacy and medical privacy in media is that there is a freedom of the press, talk about freedom of speech, which helps the commercial sector. Freedom of the press helps the media. And anything that's considered newsworthy can be published without the permission of the subject, which means that if you're involved in an accident, the accident scene may be publicized. If you're in a rescue helicopter, maybe that's exciting news and it can be publicized. To get hurt in an unusual way, maybe newsworthy. So the media benefits from a generous interpretation of the Constitution, which says that that the public has a right to know that which is newsworthy. The media is the guardian of judgments about what's newsworthy, and not the courts. So that's a problem. Okay, it's a problem. People have unsuccessfully generally sued to complain about that. Your point about the television shows and being in the media, being on TV, blogging and so forth about health issues, that's the burden part I was trying to start with, because it is a burden to give up those professional opportunities. You could make a fortune writing a book about your patient's unusual medical problems. Or being a TV star in the healthcare field and being able to talk openly and slightly veil voice about your patient can reap you great professional and professional rewards. So it's a burden to not do those things. And the thing we have to ask ourselves as professionals is, when we decide to put on that white coat, are we just simply eating that burden and bearing that burden? Or should we, in this age of tell-all, et cetera, go the opposite direction and say, it's good for the public, it's good for me, there's more value in openness than in being closed. There's a great deal of value in educating the public about medical matters. We need to be talking about our breast cancer. We need to be talking about that. So that's one take. On the question of, is there sometimes too much privacy? The Virginia Tech case raised that question very, very neatly. And would it have been good for his medical information to have been known to more people? What good would it have done? It's not so clear. But there was a sense after the fact that if only we had known. I must say I'm a little bit leery of letting extraordinary tragedies cause us to do away with privacy protections. 9/11 was a national tragedy, which in the aftermath of which we changed our privacy laws to make it easier for the FBI, the CIA, and the police to talk to one another, share information about us, collect information about us, tap our telephones, come into our homes. We softened the rules in order to facilitate this important public agenda. And I think some of what we did was great. Some of it was, I think, overkill. So I worry about letting extraordinary events change our underlying norm about the importance of confidentiality. On the other hand, if you can prevent an imminent crime from occurring, your patient tells you, I'm going to kill Tatiana, then I think you do owe it to society to put aside privacy and to, in fact, disclose a confidence that you may be privy to.
Hi, I'm Megan Rowe, and I work in the marketing department, and I actually manage some social media accounts for the health system and the medical center. And so I was curious about the nursing student placenta case that you mentioned, and you said that one of the things that the court said was the nursing school did not have a specific policy against this kind of behavior, so therefore, they had to let her back into school. And I wondered if you felt that that sort of sets a precedent where, a hospital might say we don't need to have a policy against disclosing patient information because it's protected under HIPAA, and we don't need to have a policy about something like the placenta case because, that's common sense that our staff should behave like that. But if that would lean towards you should have a policy, for everything and be conservative.
Right, so what was interesting about the case is that, yes, it wasn't good enough to just have a general confidentiality policy or to have HIPAA rules being taught or promulgated and enforced in your facility. I think the judge wanted to see a specific rule or policy that would have clearly communicated to those young ladies that they shouldn't do that thing. But then you can't have an individual rule for every possible thing that could go wrong or every possible type of disclosure. But clearly failing to have more detailed rules doesn't work so much to help, especially students, figure out what exactly are the lines that I can't cross. And it's not going to be obvious, I think, especially in this era of revelation, what can and cannot be published. So I think that today, unfortunately, one of the things I would conclude is that we need to have not just the big rules, the HIPAAs and the state confidentiality rules, we need to have the little rules as well. Okay, so when we're doing our dissection, we don't do X, Y, and Z to our cadavers. We don't in our OBGYN nursing training, we don't photograph and publicize the placenta. You might need rules of that granularity in order to help to sort of to really direct people who, for no bad reason of their own, won't necessarily get that there are some underlying concerns that need to be gotten.
Hi, Anita. John Aris here from the Bioethics Program and Philosophy Department. Anita, so you showed how valuable privacy and confidentiality are. you've shown how they really protect and are protected by old-fashioned virtues, and that the erosion of confidentiality and privacy really threatens some fundamental values that we have held dear in the past. I'm wondering if we might approach it just for a minute from the other side, and if there's anybody here who's under 18, they might be able to help. Are there values to this kind of openness that we might be ignoring that might be counterbalanced against the threat to a lot of these traditional, old-fashioned, fundamental values?
Yes, there are. And in my book, I do spend quite a bit of time, John, thanks for the question, talking about the good things that come from the era of revelation, from openness about health matters. I think it was a very good thing that, for example, Michael J. Fox went public with his Parkinson's, that President Dole went public with his erectile dysfunction, that women like Elizabeth Dole have been public talking about their breast cancer. Openness, I think, makes us understand that we're not alone when we have our health problems, that openness can also point us toward resources. Oh, she had stage 4 cancer, she went to Mayo, maybe I should go to Mayo too, And on some of these discussion forums, I visit a lot of them. I don't contribute, but I visit and I'm voyeur of them. I see patients exchanging valuable information. My husband, when he was stage 4, he chose this drug and not that drug. You might want to try it. So this exchange of information can be very, very helpful. It can even save lives. So I am not by any means trying to say, as I talk about privacy, that we shouldn't appreciate the value of openness. It's very important to be appropriately open. What I think we've kind of fallen into, though, is a kind of self-indulgent openness that's not clearly geared toward public education, public health, or anything. But to me, it's actually a good thing. The feminist in me loves the fact that women can have their babies live streamed on the web. That's great. But at the same time, I worry about the consequences for the doctor-patient relationship and also for the future lives of people. One of the things that happens if you decide to tell it all today, that then forecloses some futures for you. Our law students have had to face the fact that if they publish their drugging and drinking and partying too much on Facebook, when it comes time for them to take the bar exam and get a job as a law clerk or a lawyer, they may not be able to, because judgments will be made about them based on what they disclose. And I think this also pertains to some health information as well.
Hi, my name is Matthew Thomas. I'm a genetic counselor in the pediatric department here. I was wondering at what level the companies, the Facebooks, or in my world, the genetic testing companies, something like 23andMe that's offering
Yes.
a version of full genome sequencing for $1,000 for early adopters. And with the Facebook example, I don't think that the average user knows when they submit their photos or any information, it's now the property of Facebook. And they have rights to do with it as they please. Even if you delete your account, that data stays up there. Even though that may be written in a consent document somewhere that you sign when you create your account, the likelihood that people are actually reading that, I think, is pretty small. And I think the same goes for a lot of the other situations likely to this genome sequencing, where you can have your genome sequenced for $1,000. It's a great deal. It opens a can of worms. But they keep that information and do with it, again, as they please. And they say they're doing it anonymously, but if they're sequencing your genome, it's not really anonymous. So my question is, how do you transition from, okay, what is really consent and what's an informed decision making? Having, paragraph after paragraph of text that most people aren't reading, is that really considered enough consent for people to decide whether or not they should be doing something, or at least doing something as an educated person?
So one of the reasons why I defend privacy paternalism in my book is because of that exact problem. And the problem is that people do not have adequate information before they commit themselves to disclosures that, whether it's of a genetic code or of their medical history or otherwise, they don't have enough information to know what am I buying when I decide to go on Facebook or decide to send my sample to 23andMe. And that lack of knowledge and the information disparities, I think, in the whole world of social media, for me, suggests that there's a role for government in imposing obligations about data retention, data access, and third-party disclosure on industry. But so far we haven't seen a lot of movement in that direction. We protect children under 13. Internet operatives are not allowed to collect their personal information. But at age 13, you're free game, right? And while back in the 1990s, for a brief moment, it looked like we were going to get a national privacy statute that would address some of these concerns. As things have gotten harder and harder, we still don't have any kind of national law that would help us to bargain better with Facebook, force Facebook to not force us to bargain with them, give us fairer terms. And so at the moment, it's kind of a little bit of a wild west out there, which means that people have to be very careful and protect themselves. But again, the impetus to protect yourself is not very strong when you don't really understand what's at stake. That's why I think that it sounds a little bit trivial, but the education thing is very important. One last point, I met a couple of semesters ago with a group of Penn undergrads, very bright young people. And when I told them that employers were allowed to go on Facebook and read their Facebook pages, they were shocked. Isn't there a law against that? Well, no. They just assumed that somehow what they felt was a bad norm had to be embodied in law somewhere. And when furthermore I told them that, of course, the government could get access to their Facebook pages through subpoenas or court orders, they were further shocked because they really believed that they were creating a little intimate world of them and their chosen friends, and that somehow the grown-ups were protecting them, from the impact on their careers, on their education, on their lives.
A stunned silence there. So should physicians in practice have Facebook pages?
I have a Facebook page. Don't look at it, please. It's really, I've lost control of my Facebook page. There's no reason why physicians in practice can't be on Facebook, but obviously you have to be careful about inviting your patients to have conversations with you on Facebook that are too revealing, which might mean that you have a very private Facebook page, a secret page. My family has a secret Facebook page that people cannot just post their, "Thanks, doc, I'm feeling much better, the diarrhea is gone," so to kind of comment on the page.
Hi, Terry Ryan from the Investigation Review Board. Driving over here today, I was listening to public radio, and they were having a conversation, and one of the commenters announced that now the comments people leave on Facebook are being indexed by Google with identifiers.
Yeah.
And that they're not just these little private things. I'm just interested to hear your comments on the impact of that.
There is so much commercial value to data about individuals that any clever way to get access to data is going to be explored by the commercial sector. Google is not there to just provide us with a great browser. They're there to make money, as is Yahoo, as was Yahoo. All of it, they're there for a reason. There's value in information, and so we have to understand that what even may seem like a great freebie that we're getting, you're giving up something too if you put your name in your information. So it troubles me that Google Mail, for example, they scan all your emails. By the way, if you don't know this, you have Google Mail. All your emails are scanned, and interesting terms are pulled out of the email, and then advertisements are fed back to you based on what you say in your emails. And it's not against the law. It's something which, again, the idea where we can anonymize it or it's not, So these are real problems that I think we need to face going forward. And I think that there is a role for the FTC and for public law in trying to help us through this period with a little bit of paternalism to make it safer for us to travel in this Wild West until we kind of get it figured out and understand it better.
Hi, I'm Donna Chen. I'm one of the people who teach in the medical education curriculum here in ethics. One of the questions I had was the role of professional norms vis-a-vis policies and law with regard to things like take the placenta case as an example. If the law fails to support when professionals try to enforce their own norms, and one of your solutions was, well, we do need more policies and little rules about these kinds of things, how are we ever going to then make professional norms matter in this type of thing?
Yeah.
And I wanted to get your opinion on which was actually the better way to go.
Often the debate is posed, as you did, norms or law, which one? I think both are incredibly important. I think that in addition to recognizing that it can be harmful and offensive to publicize information or body parts, I think that we've also recognized that we need to better help professionals understand why those things matter. So I went back to the question earlier. I do think that maybe more granular norms are going to be useful, because as the amount of data and the ease of accessing it and ease of transmitting it increases, we may need more and more granular norms so people understand exactly what they can and cannot do. And I think that if people don't understand what they can and cannot do, all the law in the world won't help. But again, it's not unique to healthcare. In the business world as well. I remember people in the business world saying, Graham leached blindly, it's all, if the government imposing rules, ethical rules on the business sector. Ultimately, it's the individual corporate officer, director, manager's own values that count the most. And I sort of get that. I get that. There's a sense that somehow, unless the people internalize the norms, the appropriate norms, all the Graham leach bodies in the world won't help, because people will try to evade the norms, try to work around them, bend them, stretch them, get away with stuff. So I'm definitely a both law and norm person. I think what makes my position a little bit unique is that when it comes to law, I'm not only in favor of laws that empower people to do what they want to do, I'm also a little bit in favor of laws that may seek to impose on people restrictions which are good for them, even if they haven't yet figured out that they're good for them. And I think we're in a time right now when we can't rule out the paternalistic privacy law that maybe disallows you from posting certain things online. I'm all for that.
Anybody with a last question? So in a sense, you would favor passing a law that allows those of us who sometimes feel this is too much information, that we wouldn't have to be saying that about some of what we see.
Yeah, and I try in the book to show that adults today, many adults suffer from some of the same vulnerabilities that young people do, and that for that reason we have to be in the mode of let's use our ethics and our laws to protect this foundation for privacy. Thanks.
Thank you so much. We would invite you to join Anita Allen and many of us later this afternoon, 4 o'clock in Clark Hall 107, for a talk on moral life and mental illness. And then next week we have 2 programs for Medical Center Hour, both exploring the creative work of dancer and choreographer Bill T. Jones, who will be at UVA in residency all next week. Next Tuesday at 5:30, the 8th of November, in this room, we're going to be showing a screening of documentary film Bill T. Jones, Still Here, with Bill Moyers, about a 1997 choreography project that drew on the experience of persons living with terminal illness. And then at Medical Center Hour next Wednesday, Bill T. Jones will be our speaker, and he'll be offering a meditation on that work, Still Here, and what it means to him and his work and to us going forward. So we'll look forward to seeing you there. Please, a fine hand for Anita Allen.